The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everybody. It is Lunch and Learn. It's Wednesday, November 6th. Today we have a guest speaker, Tiff Thompson. Tiff does a nice job talking about artifacting. She did this workshop at ISNR, and it was really well received, so we asked her if she would be willing to do that with us, and she's agreed. We were having some technical difficulties, and we're having some sound difficulties, so we're going to keep everybody muted while she presents, and towards the end, we'll try to see if there's some time for some questions. Otherwise, if you have questions for her, you can email them to me, and then I'll forward them to her, and then we'll post those up on the list if we don't have enough time. So, Tiff, thank you so much for being here. Appreciate your willingness to do this for the New Mind group, and it is all yours.
Awesome, great, okay, good. So yeah, thanks again, you guys, for having me. Really generous, and what an honor to be talking to this group of people. So I have 50 minutes to get through all different kinds of artifacts, and that's exactly what we're going to do today. So generally, when we start recording EEG, people get a little bit perplexed, and they say, I have no idea what to pick. How do I even decide what's real and what's fake? And we get into some sort of artifacting paralysis where it takes an hour to artifact an EEG. And so the point of this lecture today is to help you distinguish real data from fake data, to give you some tips and some tricks that'll help you make it through the muck. And so ABCs to begin. You all know this, but recording etiquette. When we acquire an EEG, I recommend that you have a script that is rote and something that you say every time to everyone, regardless if it's their first session or their 100th session. People like consistency, and they like to know what to expect. And so my script is, so go ahead and relax the muscles around your eyes, relax your forehead, allow your tongue to slide away from the roof of your mouth, and allow your teeth to slightly part. You're going to have some version of that, and assuming that their eyes are still enough, and if in case they're jiggling, you would say just go ahead and place your peace fingers, your middle and your index finger, over your eyelids during an eyes closed, and you're off to the races. And so again, very elementary, but before they come in for their initial EEG, there's some rules of thumb. Don't drink alcohol the night before, try not to party the night before. I'm okay with people having a cup of coffee, but not a pot of coffee. Come in fed, take your medications as usual for the most part, limit hair products, get a good night's sleep. Please don't come in drowsy. These are some of the things that if you have a front desk staff, you're going to want them to know these pieces. Otherwise, you're going to be instructing your patients to come in their best possible selves, which, as we know in this field, is not always the best. So we take what we can get. So what qualifies as an artifact? An artifact is extra cerebral, not of the brain, just like an extracurricular activity is not of school, right? So today, we're going to get through muscle artifacts, eye blink and eye movement, glossokinetic, drowsiness, sweat, EKG, salt bridge, electrode and equipment artifacts, medication artifacts, and environmental noise artifacts. So we have a lot ahead of us. So first things first, so back to the initial EEG. Why is this thing hard to artifact? And so as you look at it, you might say, yeah, it's because everything looks the same. And what you'll find is that often, not always, but you'll have EEGs where everything looks the same, all the lines look the same. And what we're dealing with here is we're dealing with something that's called, or that is, a contaminated reference, right? A contaminated reference, the ear clip. When we have a contaminated reference, which I'll explain in a moment what it means, we have what's called shared variance. And shared variance is essentially something that is taking the same waveform and smearing it through all of the data, smearing it through every channel due to common mode rejection. So you'll see on the left we have each electrode compared to the linked ears. And we have a very uniform looking EEG where everything's moving up and down in large part in synchrony. It's locked in phase. And the truth of the matter is that is a violation of Gauss's law of electricity, which in a very small nutshell states that everything within a sphere has to equate to 0. So for every up, there is a down. When you see your EEG marching in lockstep, each line together, know that you have something going on with your ear electrodes. And this is the sneakiest part. Often, it's not that you have a bad piece of equipment, but it's that you have a loud source coming from the temporal lobes. So that could be T3, T5, F7, T4, F8, T6, meaning T3 is trumpeting out, in this case, a delta. And that delta is being picked up by A1, by the ear electrode. And that ear electrode is then distributing the delta to every electrode that it is being compared to. And so what we end up with is an EEG that has a false global representation of, in this case, delta. So if you find that your EEG is in phase, you're going to switch to an average montage to avoid contaminated records. You can see that picture 1 on the left and picture 2 on the right look very different from an EEG perspective. But if you look at the waveform that's showing up primarily in the left, and then you look at the right, it's coming from T5. So I switched to a Laplacian montage in the right picture, which is a average weighted montage. Now what I'm doing is I'm comparing each electrode to the surrounding electrodes, to the average, or in this case, the weighted average of the surrounding electrodes. I'm taking the ears out of the equation. So there's no more contaminated earlobe. The neutral spot that was not truly neutral has been removed. And what it's revealing to us at T5 here is that it was T5, that left posterior temporal lobe, that was trumpeting that slow wave out throughout the entire record and effectively confusing us. So this is an important point. It happens in about 50% of EEGs. So you're going to want to switch. This is one of the importances of montaging. Montaging will allow you to see where things are localized. Laplacian and average, a Hjorth, these are all different forms of average montages. So in this record, we have a really sneaky example. And as I cruise my mouse around, what I'm doing is I'm saying, is this record in phase? Is everything moving in lockstep? There seems to be quite a few moments where it is, and that's the trick, is that it's not going to be every single electrode every single time, but it will be frequent enough that you can just go ahead and track, wow, everybody's doing the same dance at the same time, up, down, up, down. So what I'm going to do here is switch us to a Laplacian montage, and that alpha that was so widely distributed in the whole record before, now we've localized it. Oh my gosh, the whole time it was at the left temporal lobe, it was at T3, and what was happening is that that little left ear electrode, like an antenna, was picking up that alpha waveform and distributing it throughout the entire record. So this is a piece of information that even the most seasoned clinicians don't necessarily know. And so hopefully it's something that stuck. And if it didn't, I'm sure that the recording can be shared. So let's get into types of artifacts. Muscle tension. Easy to spot, so we think. And there's ways to determine whether it's real or fake. One simple way is it's usually going to be 1 or 2 channels. You don't, in real EEG, in a real brain activity, you don't see one channel doing its own thing. They have to have partners. The brain doesn't work in isolation like that. And so the higher the amplitude with increasing frequency, like we see here on the right-hand side, the greater the chances it's muscle imitating data. On this graph, of course, we have on the x-axis frequency and on the y-axis amplitude, and we see one electrode is running astray. Okay. And so we're going to talk about all the different muscles, where they show up in terms of EMG artifact and how they show up. So in this case, we have somebody who is clearly chewing. You will find this happens when someone comes into your clinic with gum in their mouth, unbeknownst to you. And in this case, this was an individual who had a mental handicap, an older man, and he happened to just chew a lot. And so when someone can't stop chewing, you simply have to edit around the chew. But that's the masseter muscle, 50 to 60 hertz, fairly obvious. The occipitalis, however, is not as obvious. So the occipitalis is generally going to run 20 hertz to 300 hertz. And it's these two little rectangular shaped muscles on the back of the head. And so you'll find that individuals with short, squat necks happen to have this type of EMG. So what I'm going to do here is I'm going to take off the low pass filter. Boom. What I've done there is now I'm allowing everything beyond 40 hertz into the EEG, right? And what that does as a first line of defense is it allows me to say, and I'm going to play this one more time as I complete my description. Ooh, we have some beta happening at 0102. It has rounded tops. That's the morphological signature. Does it really? If I remove the low band pass, what happens? Ooh, it gets hashy. It gets spiky, right? And that's one of the first ways to determine, is it real or is it fake? Muscle's going to show up in diphasic spikes. If you touched your finger on the tip of it, you would prick your finger. It's going to look like this in a map, and I'm referencing a NeuroGuide map, but any map is going to say to you, in this case, something like, oh my gosh, this individual has 4 standard deviations or 4 z-scores, more beta and high beta occipitally than we would expect. Now, what we actually have is some muscle tension happening in the back of the head. And what's interesting about this is if you look at the subsequent rows, we have artifact rocking its way through the entire quantitative EEG. So the red is coupled by a deficit in relative delta and theta that's also fake because the relative beta is fake. The amplitude asymmetry is a reflection of the power differential between the back of the head and the front of the head. Also not real because it's occipitalis muscle. Same with some of this stuff back here in the hypocoherences and the hyperphase lag. So we can see just how impactful EMG can be. So what if I can't tell if it's real or fake? Here's another trick. You ask, do the neighboring electrodes have the same field in the same phase? That is to say, do they look the same? So here's a quick example of checking for field and phase. What I'm going to do here is first line of defense. I'm going to say, okay, is it real, is it fake? Let's drop that low pass filter and see what happens to 01 and 02. Oh, questionable. Maybe it's real, maybe it's fake. And so in this video, I take us over into WinEEG, another software program, which allows for me to do this cool move, right? Boom, look at that, they match. They match. And so muscle artifact is not going to match. That is to say, real muscle artifact will not have similar field to surrounding electrodes, nor will have similar phase. They won't match if it's fake, and they will match if it's real. So let's learn about muscle anatomy. The frontalis is a muscle in the front of the head. The ones that I'm going to hit up, we've talked about occipitalis. The one on the temporals is called, guess what? The temporalis. So now you know what to call all those muscles. The frontalis is due to wrinkling the forehead, frowning, scrunching, and it will show up in a map like this. We're going to have excessive high amplitude, high beta, and just like the other map, we have amplitude asymmetry, hypocoherence, and phase lag that are showing up as deviant. All of these metrics, even the deficit in relative delta and theta, they're all a consequence of false data to begin with, right? And so we know about these metrics now, and we know about these steps. You can drop the low pass band filter to check for muscle. You can check for field and phase. And so let's see one more example of that. This is someone that came in and look at all that frontal beta, FP1, FP2. They're coming in, it comes in wavelets, which makes me think it's real. Nice rounded tops, which also makes me think it's real. Comes and it goes, waxes and wanes, travels in envelopes. So I'm going to take us to a day med montage first. Now, what DayMed Montage and the NeuroGuide at least will do is it will place the channels sequentially. Does FP1 link up to FP2? Yeah, I mean, it looks like they could fit together. Yeah. And once more, do these two fit? And as a matter of fact, they do. And so when I see this individual's map with excessive high amplitude beta in the front of the head, I can rest assured that it's real. So, as I alluded to, the temporalis muscle, this is one that we see quite a lot impacting T3, T4, F7, and F8, occasionally T5, T6. And in this case, we see that F8 is running alone. It's dancing to its own dance. It doesn't have any neighbors that are doing the same thing. And so what that's going to show up in a map is going to be this high amplitude right frontotemporal beta. Same thing, right? We look at relative power, we say, oh, there's a deficit in delta and theta. That's due to the excess in relative beta. And the amplitude asymmetry is a reflection of the power differential at that site, as is the hypocoherence at F8 as well. That F8 is going to look something like this in your spectra, where he's running alone. So beware, be suspicious of the solitary electrode. Now in this case, we have the temporalis muscle throwing T3 and T4. This is a little bit more common. That is to say, you've seen this in your maps. You've seen people that have EMG at these two locations. They're known for it. And so what normally happens is we would see this in the spectra, and we would see red spots at T3 and T4 in the map. Regardless of what software you use, you're going to end up with a contaminated map, and it's something that, worst case scenario with your patient, you'll have to explain it, but you can say, oh, don't worry about that red spot at T4. It's EMG, it's jaw muscle. However, there is another way to get around it, and it's, I guess, a more advanced form of computational neuroanalysis, but it's not that hard, and I believe it's the direction that our field is going. And so it's using independent component analysis cleaning. And to be real simple about this, I'm just going to remove what I'm seeing there at T4. In this case, it's called T8. I'm clicking on ICA, and what this program is going to do is it's going to isolate the different components in the data, and I'm going to look for T4, for that nasty loud bugger. And when I find him, and in this case he's the second and the third component, you see head number 2 and head number 3. The red dot and the blue dot signify two different dipoles of the same phenomenon. So what I've done here is I've removed that piece of data from the EEG, and I've cleaned it. And there's an argument in the field as to whether or not this ruins data by altering phase and field. And you know, it alters data for sure, but I think it alters it for the better, because now we can see what's happening outside of that artifact. So let's move on to some more simple ones. So we think, right, pulse. So you can see here that we have a pulse artifact. How do we know that? We know that because it's rhythmic. It happens about once a second, and an average blood pulse is going to be 72 beats per minute, 72 BPM. And so here we have roughly a beat a second, maybe just a bit faster. Now, here's a trick, and it's something that makes this all the more exciting. When we're looking at every single line here, we're saying, yep, I certainly see that heartbeat. It's happening everywhere, sure enough. Now, we know from earlier what that means is that there's a contaminated reference because it's happening in every single channel, right? Okay, so here's the million-dollar question. Which ear reference, which earlobe is carrying the heartbeat? Which earlobe is contaminated? Which earlobe is not neutral? And you say, I don't know. Well, look at these lines, and here's my question. Which ones, or which one, seem the most clean or the most sanitized of that heartbeat? And you say, well, it looks like that T3. doesn't have as much of a heartbeat as well as T5. They're not quite as strong. So here's the trick. Where you're not seeing the artifact, in this case, where you're not seeing the heartbeat, is where the heartbeat is. Because of common mode rejection, T3 in this case, minus the linked ears that has that same heartbeat in it, it's removing the heartbeat from the channel, right? And so this is really sneaky, because now when we eyeball EEG, even if we have only linked ears, you can often trace where the bad guy is simply by finding out where he's not showing his face in the EEG, right? That's the one that's going to be closest to the contaminated ear electrode. So you would find this type of artifact in someone like a Danny DeVito, someone with a squat neck, a neck that kind of like moves right up into the head. Sometimes you just can't get away from it. You could, however, switch to an average montage and do better. So here's some questions. Real or artifact? Question: if I'm contemplating whether or not this is heartbeat, is it rhythmic? The heartbeat has some variability, as we know, but it's generally going to beat, you know, pretty rhythmically, around 1 hertz, sometimes 2. So EKG doesn't always look like we just saw. In this case, spot the channel where the heartbeat is coming. Okay, what do you think? FP2? If you thought FP2, bingo, spot on. So what we have is about once a second, boom, 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 a heartbeat, right? You can actually see a little bit of it in F8 too. It's rhythmic, it's slow, it's not real delta, even if it looks like it's 1 hertz, it's a heartbeat. And so what that's going to show up as in our maps is right prefrontal, FP2, delta. So if all I have for this individual is this map, and I don't have the ability to clean this from the data, I will say, so here we have your Z-score map, but don't mind that yellow dot at the front of the head on the right-hand side. That's just a heartbeat artifact, and that's totally acceptable. So a heartbeat can be in all channels, or it can be in one channel. On to elementary EEG, eye blinks, right? So we all know how to identify it. It's going to be coming from FP1, FP2. The eyes are powerful dipoles, and so every time you blink, they actually dip up and down, or bounce up and dip down. And so they have a positive and a negative polarity, and they cause a wide polarity shift when they move in the data. I believe for this reason is why EMDR is a powerful technique for altering hardwired memories and things like that. And so we can avoid eye blinks, but there's a subtle trick to avoiding eye blinks so that you get the best possible data. And it is this: avoid including what I call the whiplash in your accepted data. And if you have somebody that cannot stop blinking, what you're going to do is say, okay, Jimmy, do me a favor. When you blink, try to not blink after that for about 5 seconds. And if they can't do that, say, okay, try for 3 seconds. Another way of saying it is, what I'd like you to do is get a couple of good blinks in, and then try to not blink for 5 seconds. That's hard for some people, but I'm sure you've all had to work with a really blinky record, and what you get is a ton of whiplash, this deal, right? It's almost like we gear up to blink. It's like take a big breath and blink, and after the blink, it's like there's this wave that rolls out, and so you can't accept the whiplash right there. If you did, then the fast Fourier transform processing algorithm would say, oh, well, this person has frontal delta. And that would not be true. In fact, I would recommend that you question frontal delta or any delta in a quantitative EEG. Make sure that it is the real deal, because delta indicates white matter cell death and is generally pretty severe. Now, in this case, I'm not going to get any of the whiplash from the blinks. I'm going to avoid them altogether, and it will produce a nice clean map. It's a general rule of thumb. You want to accept data that is consistent. And so I'm pausing the record here because if you paid attention, we just had a state change, right? We just had a state change. So up to this point, we have a lot of beta, right? Low amplitude, organized beta. Now I get to the next place in this record, and oh, what do we have? We have alpha. So what alpha is going to do, let's say I were to choose this, it's going to alter my the validity and the reliability of my test. So I'm going to accept this alpha, and it's taking those numbers, which were 0.9 in terms of the reliability, and it's making them a 0.7. Right. So the point in this is, if you find that your numbers in terms of the validity and replicability of your data, if they're poor, chances are you have two separate states. And in this case, we just had someone that entered an alpha state for a moment, but I would not accept that alpha data if the rest of the EEG was pretty consistent. And so unless somebody has a significant change from state A to state B, I would just stick with one state. However, if there is a significant change, you can get two maps from one recording and show them two different states that they're inhabiting. Lateral eye movements, F7, F8, right? So check it out. It's almost like F7 and F8 are coming together and kissing right in the middle there. And this is a very subtle eye movement. It's not like someone's really looking left and right. This is just little eye saccades that are happening beneath the lids because we have alpha, so we know that the eyes are closed. Lateral eye movements are second only to blinks in terms of their prevalence in EEG. So when you're scanning your data, you're always going to want to look for delta at F7, F8 to ensure that you don't have lateral eye movements in your record. And so what it's going to produce is a map that looks something like this, right? And so you, the savvy clinician, put this map in front of your patient and you say, see that frontal delta? Have no fear, it's not real, that's not yours. What we actually have there is some lateral eye movement that's contaminating the data, but it's okay, right? And we can also see, again, if you look down, amplitude asymmetry is kind of getting thrown a little bit, saying, oh, we have some asymmetry coming from that right frontotemporal. Not really. We have some lateral eye movement that is asymmetrical to the rest of the data, right? So, salt bridge. This is something that I think we've all come across at some point in our careers. I remember the first time I saw one, it was on my brother. I got an EEG on my brother, and I said, I don't know what this is. And so someone told me, thank God, that day, oh, this is a salt bridge. So a salt bridge usually happens between the ground and FZ in an EEG cap, right? Especially if your ground is right in front of FZ. Those two electrodes are really proximal to one another, and if you put too much gel in one or the other electrodes, what you'll cause is a river of sludge that moves between the two, and it's a salt impregnated paste, right? And so what happens is we have a short circuiting of those two leads, and what it will produce is a subharmonic of electricity. And the subharmonic of electricity on a 60 hertz grid, like we have in America, is going to be 28 hertz. And 28 hertz has to do with the difference in the grid itself and the sampling rate. In this case, it's 256. So it's also called the alias, right? When you see a 28 hertz spot, like we do here, for instance, at any electrode for that matter, or another subharmonic of electricity, a 16 hertz spot. And it's going to be focal like this. It's going to be really mad, really hot at those frequencies. Know that you have a subharmonic of electricity. In a spectra, it would not have what's called kurtosis. The spike that represents that 28 hertz at FZ, it wouldn't have sides. It would just kind of go bink, bink like a needle. And so this is not real. And what it's causing is, in the summary page, amplitude asymmetry. It says, oh man, that FZ is much bigger than the other spots in the head. Well, not really. I mean, we just have an artifact. And in coherence, see the blue part in the hypercoherence, that's phony as well. So beware the salt bridge. Environmental noise. So whether you're on a 60 hertz grid or on a 50 hertz grid, you sometimes can pick up environmental noise. It's a bummer when it happens because it's usually the result of not being grounded. And that could happen for any set of reasons. The first time I saw this in my clinic years ago was when I was living in an old house, and the plug into the wall was a two-pronged plug, so it didn't have that third part of the plug, which is the ground. And what I ended up picking up was electrical noise. And so in this case, how do we know that it's environmental noise? Well, for one, it's rhythmic. And the brain doesn't operate like a machine. It's not going to kick out a rhythmicity that is tick-tock like a clock. We see there for a moment it disappears, right? But then it comes right back. So your naked eye should say, something's afoot. This isn't quite right. And you know, after seeing enough of them, you'll say, oh, this is electricity in the EEG. It happens more often than not. There's some ways around it. There's grounding mats. You know, I've known people to have actually done work on the structure themselves. I highly recommend, if you're moving into a new office, though, you go in with a cap on and your amp in hand, and you move from room to room, and you make sure that you don't have electrical contamination, because it can really muck up your data. So on that note, let's move into equipment and electrode artifacts. Electrode artifacts themselves are generally brief transients that happen one channel at a time, right? The one channel at a time piece is where you say, aha, it doesn't have field or phase. There's nobody else doing the same dance. A transient means that it's going to come and go. Okay? An electrode pop is a spontaneous discharge of electric potential. And usually there's like a little air bubble in your gel, or your electrode isn't secured well enough. And so you have a resulting pop. And lastly is a loose electrode. And a loose electrode, it can happen for any reason. Even if you have spectacular impedance, if that individual shifts or moves, if they lean back against a chair and that electrode moves, what that's going to create is compromised contact and resulting disorganized morphology. So in this case, what we have is a loose electrode. So pay attention. And you might say, oh yes, I see that there. Now there's not one but two, right? There's one in the middle, and then there's one near the bottom. And then they stabilize again. That one near the bottom, he sure is doing his own thing. So I know for a fact that what we have is a loose electrode, or in this case, a pair of loose electrodes. This is a particularly sneaky recording, because in the beginning here you see, wait a second, are they sharing field and phase? Are they doing the same thing? It almost appears that way in the beginning, but no, actually they're not. One could not fit into the other, right? They are not doing the same dance, although it's a You know, it's variations on the theme, but we certainly have artifact because we have two electrodes in this case dancing to the beat of their own respective drums. So this next record is an important one to become accustomed to recognizing when you see it. This is shared variance, but it's due to a bad ear lead, right? And so we've talked about contaminated EEG that's due to a loud source in the temporals. For instance, a loud theta, a loud delta. Those are generally the culprits for real data that's contaminating the entire record through the ear electrode. This video that I'm about to show is a bad ear lead. And so you're hooked up and you're recording away and you notice something like this happening where every channel looks absolutely identical. Soup to nuts all the way through. So what is going to happen when you have a bad ear lead is we're going to see every channel sharing the bad ear lead, essentially, and it's going to end up looking like this in your maps, right? It's going to throw your coherences. It may throw your phase. This is not a salvageable EEG, and what it's cranking out is what I call spaghetti head. When you see spaghetti head and coherence, and almost always it is every single frequency band, delta, theta, alpha, beta, high beta, everything is synchronized, right? Everything is in lockstep. And so what we have is a bad ear lead, one that you're going to throw in the garbage. So if you see a EEG coming across your plate that's looking like this, you say, shoot, I have a bad ear lead. Hang on, let me replace it with a good ear lead. And you're going to have to test both of them, right? But in this case, we have a equipment failure. And what's unfortunate is I've seen presentations where individuals have said, and competent individuals in the field have said, I had a patient who had this insane hypercoherence, and then after this one treatment, it went away. And so it's important to recognize when you have bad data, because other people may if you don't. Here's another record that is a sneaky one, electrode pops. So a pop and a loose electrode, they're certainly in the same family. Oh, there it goes. Whoa. O2 is really doing its own thing. Whoa, 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 whoa. Right. And so, yeah, as a clinician, your first thought, especially if you're not super familiar with raw data, is you may say, oh my goodness, do we have a seizure here on our hands, right? We have this loose popping electrode. And you don't. That's the good news. You don't have somebody that's showing any epileptiform discharge. That has field and phase, right? That's multiple electrodes doing the same thing. And so one of the humbling things in this field is that we earn our stripes. And the more we know, we turn around and look back, and we can see what we didn't know in the past. And if you're doing your work in this field, that phenomenon never stops happening, which is really grounds to remain humble, because we're never going to get to the bottom of it in terms of the brain. What we're seeing here is a representation of the most complex noise in the known universe. And we are very fortunate to work with the most complex noise in the known universe. And so to presume that we know all of it is folly. And I would run away from anybody who presumes to know all of it. So let's get into some more complicated examples, just a few more here, and then we'll wrap it up. Drowsiness, drowsiness. So when we're falling asleep, in the beginning, we generally slip into NREM1, NREM2, N stands for non-REM3, non-rapid eye movement 4. So in this case, we have somebody that is slipping into NREM2 and 3, right? And what happens when someone goes into 2 and 3 is they start to really fall asleep. And at 1 minute in, as we are here, what we probably have is somebody that either has sleep apnea or is severely sleep deprived. You'll find that if someone's falling asleep that quickly in your chair, that's what's going on. So I'm going to hit start. Now, right out the gate, I'm going to hit pause just so we can hold this slide. You'll say, oh, that looks like alpha, but then let's count it. Is it alpha? 1, 2, 3 bumps per 200 milliseconds. No, we actually have a beta, right? We're at about 15 hertz. So we have a spindling beta. And then what we start to see is some central vertex slowing. So pay attention to the last 3 lines, the middle 3 lines. There's our beta spindles. There's our vertex slowing. Yeah. So I'm going to hit pause here. This combo is what's called a K complex. K complex. K stands for knock, because if you were to knock at this point in the recording, this person would not awaken because they have sleep spindles, which is a stabilizing mechanism of sleep. One of the reasons why one way to train sleep is to enhance the presence of beta 1 or SMR. But what's happening is we have the spindles of sleep paired with a vertex slow. They're drifting into NREM2, and they're soon going to make it into NREM3, and we're going to see the beta spindles start to give up and then some more delta show up in the record. But we have theta running down the midline. So this kiddo, in this case, is certainly falling asleep. Now you might look at this and say, oh my goodness, this eyes closed data is crazy. We've got central theta. We have ADHD. It's going to show up in a map like this. And it is not a good looking map. Oh, frontal beta and midline theta. We have stress and ADHD. And even some left temporal delta. So what we really have is someone who's falling asleep. And it's not fair to use this map as a gauge. However, if they were awake for the next eyes closed, you might give yourself a pat on the back unnecessarily. And so this amplitude asymmetry is a reflection of the power differential that we're seeing at theta at CZ. And the theta at CZ is due to the fact that we have someone that's drifting off into sleep. Alrighty, so sweat. If you've ever had a non-air conditioned office on a hot day, or you're at someone's house and they're sweating, or someone comes into the clinic and they've just had to climb a flight of stairs, you might get some sweat artifact. And sweat artifact is big and swingy like this. What's happening is that the salt and the wetness, the moisture in their on their head is impacting the salt impregnated paste in the electrodes. And you'll find the same thing when you have somebody that comes into your clinic with wet hair. So if someone comes in, for their 8 a.m. map and they have a wet hair, you better have a blow dryer handy. I imagine most of you do, especially if you've been around the block. And you say, we got to blow dry your hair. So it's, one of our secondary professions by default as neurotherapists is that we are pseudo hairdressers. I think I'm probably one of the better ones personally, but that's just me. So what's going to happen is that the sweat artifact in most programs is going to be filtered out. So the maps are not showing that big slow that we would expect. Hey, where'd all the delta go? But what's happening is we don't have delta that is that is over 1 hertz. So everything under 1 hertz is getting omitted. Everything under 1 hertz is getting filtered out. So what you have to do then is check the filtering. This is the same person, and I'm looking at their map afterward, and I'm saying, well, there's some eye movement, but gosh, where'd all that slow stuff go? I mean, I'm not seeing any of it. So what you want to do in this case is drop the high pass filter. Now, everything under 1 hertz can come through the record. The gain automatically scales, so I'm going to shift it and what we see is that slow waveform shows back up in the record. So your filters are your friends. They're going to be helpful. Medication. Well, now when you look at this, you say, yeah, something's going on there. What we have is a spindling beta. This is a spindling beta of a GABAergic drug. In this case, we have a benzodiazepine on board. Xanax, Klonopin, Valium, something of that nature is going to increase the amount of GABA available in the synaptic gap, which is inhibitory. And so this is someone that actually has benzodiazepine toxicity. That doesn't mean they're going to fall over and die, but it does mean that they're taking too much. And in this case, this individual did not report this on the list of medications he was taking because he was taking it as needed. And he reported that he once had a Xanax abuse problem. So what this is going to do is it's going to contaminate the entire EEG because pharmaceuticals aren't going to choose where in the blood-brain barrier they come through. They're going to be universally accepting. And so we're going to have a map like this. And sometimes you'll see it in high beta too, but generally it's going to be between 15 and 25 hertz. And it's going to show up as a high amplitude beta. Now, of course, this is not something that we can disentrain, just like you can't make a drunk person undrunk. This is a medication side effect. And so the recommendation, if this individual wants to take care of that high amplitude beta, is stop taking meds. All right, so end of the road, mystery bonus point. If you get this and you haven't seen this lecture before, pat yourself on the back. Check it out. What's happening here? This was brought to us by a someone who is a medical doctor. So it's a tricky one. Well, look at the gain up here. Upper left-hand corner. We're scaling at 5 microvolts. That's crazy town. So what if we make it a normal level, 50? Let's scale it to 50. Oh, and what we find is we lose everything. In fact, there's like no data here to look at. What is it? Is it a coma? Is it brain damage? It's questionable that anything is happening. So I'm going to collect a bunch of this. I'm going to go ahead and crank out a report. Oh, first let's look at the spectrum, and we see we're really low in z-scores, and the absolute power is at 0.03 microvolts squared. Something's wrong. So we generate an analysis, and we get a very ugly head map. Blue, blue, blue. Okay, so write down your answer. And if you guessed mixed metals, you're a winner. Congratulations. So that is actually a silver ear clip, in this case paired with a tin electrode cap. So we've mixed the metals, and what's happened is it's cranked out a ugly EEG that isn't worth anything. All right, so that's it. We've made it in just the nick of time. I appreciate your presence. Thanks for listening.
All right, well, you do have a couple of minutes. We have some echo, but does anybody have any quick questions for Tiff?
Rob, everybody's muted.
Oh, then wonder.
Hang on, I had Tiff temporarily muted. I'm unmuting everybody, just so that she doesn't feed back. She's not used to muting herself, so I just muted her for her while I unmuted
Gotcha, okay.
I'm unmuting everybody else so that they can ask questions, and then I can unmute her and she can answer them. Feed back on her. All right, we've got just about everybody unmuted.
Any quick questions from anyone?
Actually, it's a slippery cap. If you want to have a slippery cap.
All right, mostly
background nonsense.
Yep.
But it was just the last like 5 seconds. I'm like, oh, come on.
Got that one.
All right, it's probably going to be easiest for those of you, if you have a question, if you would formulate it into an email and shoot it to me, I will forward those to Tiff. She can respond when she gets a moment. And she might even point to where that question might have been in her presentation, and then we'll see if we can get some answers done. So we make that the easiest since we're at the top of the hour, and I know many people have people coming in and, you know, patients and clients. Tiff, great. Thank you so much. Appreciate your time and willingness to do this for us.
My pleasure. Yeah.
Yeah,
How
great
fun.
presentation, Tim. Terrific. A lot of good details. I don't think everybody's seen so far, so that's really terrific.
I
appreciate your presentation.
Thanks, you guys. Thanks, you guys. Thanks for all you do.
Yep, thank you.
All right, well, thank you. Give a hug to your little one and to Nick from us, and we'll see you soon.
Okay.
Bye-bye.
Bye.